We are going live in 5, 4, 3,
Very good.
2, 1. We are live now.
So warm welcome to you all. We are here with the 13th episode of our series on controversies and consensus in orthopedics, what we need to know. This series is being conducted bi-monthly every Wednesday evening with a new and hot topic in each sub-specialty of orthopedics under the chairmanship of Dr. S.S. Mohanty, Secretary Dr. ASHISH PHADNIS, Dr. SWAPNIL, KENY, and myself, Dr. DEEPAK GAUTAM. Dr. Mohanty is the professor and unit head in the Department of Orthopaedics at SRINIVAS Medical College and KM Hospital, Mumbai. He is also an honorary consultant at Ashok, Nanavati and Sushita Hospital. He is the past president of Indian Arthroplasty Association and Bombay Orthopaedic Society. He is a great academician and researcher. He is the education chair of Indian Society of Hip and Knee Surgeons, reviewer of famous journals, BJJ, SICOT, and our own Indian Journal of Orthopaedics. Today is a day of controversies in trauma management, for which we have an eminent speaker, Dr. SRINIVAS KASHA, along with moderators, Dr. ANKIT KHURANA and Dr. KARTHIK SELVARAJ. I would now like to call upon Professor Mohanty to introduce our speaker and the moderators and proceed with the session. Dr. Mohanty, sir, all to you now.
Thank you, Deepak. Could you mute yourself because there is some noise coming from your side? Okay. So, good evening, dear friends. Greetings from Mumbai and welcome to the 13th episode of Controversy and Consensus in Orthopaedics. And today it is devoted to the coronal shear fractures of the distal femur. And we have three eminent faculties today from all over India to share their experience about coronal shear fractures of the distal end of the femur. So our eminent speaker today is Dr. SRINIVAS KASHA, who is a fellow he was done fellow in joint replacement and AO trauma fellow, and he is a senior consultant orthopedic surgeon at KIMS Hospital, Hyderabad. Dr. KASHA has been the Secretary General of TOSA, the Telangana Orthopedic Surgeons Association, Executive Committee member of IOA Academic Cell member, AO Trauma faculty, and his academic interest include, he's a DNB teacher, organized various state level and national level conferences in complex trauma, pelvic trauma, and hip and knee arthroplasty. I personally attended TOSACON last year, an excellent conference which was organized by Dr. KASHA. Welcome, Dr. SRINIVAS KASHA, and thank you again for joining here and devoting your time for the cause of academics in trauma.
Thank you so much, sir. Thanks for the invitation.
Welcome. And we have two eminent moderators today. Dr. KARTHIK SELVARAJ from Coimbatore, India. He is MS Ortho from All India Institute of Medical Sciences, Delhi, and done his shoulder fellowship from Christchurch, New Zealand, and Hamilton, New Zealand. Was a trauma reconstruction fellowship from Adelaide and Melbourne in Australia. He was a APKSS and ESCA traveling fellow in 2016. He is the director of KS Ortho Care at Coimbatore and past executive committee member of Shoulder and Elbow Society of India. And I thank personally Dr. KARTHIK SELVARAJ and welcome him to this episode of Controversy and Consensus in Orthopedics. Thank you, Dr. KARTHIK, for joining today. Now we have our another eminent moderator today, Dr. ANKIT KHURANA, who has done his MS from PJ Chandigarh and senior resident from the All India Institute of New Delhi. He is the assistant professor in orthopedics at BSA Medical College and Hospital, Government of National Capital Territory of Delhi. He has extensive experience in foot and ankle orthopedics, specialized in hand and upper limb surgery and skilled trauma surgery as well. His experience in pediatric orthopedics, arthroscopy, arthroplasty, orthobiologics, I think all except spine. That spine doesn't show here. He has over 32 publications with nearly 25 in index journals with 215 citations, and he has been an active participant in the Pulse Polio program for the eradication of poliomyelitis. He has done it, IPAS UAB fellowship in 2019 at UAB Alabama, USA, and ISCA Midlands Arthroscopy and Arthroplasty Fellowship in Solihull and Birmingham, UK in 2018. We welcome Dr. ANKIT KHURANA today to moderate this session, and thank you for your time for moderating this session.
Thank you, sir.
Now, without any further ado, I hand over to Dr. SRINIVAS KASHA to deliver his lecture, and this will be followed by the discussions. Thank you very much.
Sure, sir. Let me share my screen. Hope my screen is visible.
Yes,
Yeah.
it's visible.
Visible and you are audible. Thank you.
All right. Thank you. So I want to make it a bit interactive, this particular session. And please free to stop me, and you can even comment. So the topic is coronal shear fractures of distal femurs, which is also known as Hofer fracture. Let me just take you through this particular case. Here is a 30-year-old male operated elsewhere 2 months back and presented with this particular X-ray. Sir, anybody can participate. What can you actually see?
So this
Mohanty, sir.
is to be a
Yeah.
failed fixation
yeah.
of distal femur, possibly a non-union. And since the surgery is just 2 months ago, I would like to rule out infection with an ESR and CRP and go for a CT scan
Excellent.
eventually to rule out what really has gone wrong.
Excellent, sir. I think that is the CT scan available. So those are the picture. If you can make it, I can play all three at a time, actually.
So do we have a pre-operative X-ray?
No, sir. So it is operated elsewhere and patient just came with this particular picture. So I'll just again play this particular 3D picture. So what I want to mention here is your anterior shaft is completely intact in this case, where exactly your plate is sitting. If you can make that. And the same is seen on the coronal and sagittal sections. Of course, fallen apart the screws and all. But what is seen is your shaft is intact with the distal trochlea. And as you asked, CVP, ESR, and CRP are normal. Although because of the deformity, there is tenting of the skin. You can make it out. And so this is exactly what is a coronal shear kind of a fracture, wherein your fixation is mainly anterior and the condyles are missed. I'll just take you through at the intraoperative picture. So that's the medial and lateral incisions. If you can see, the anterior shaft, which is completely intact with the trochlea, and that's the condyles, posterior part of the condyles. Purely it's a shear fracture which requires some fixation perpendicular to the fracture and maybe buttressing that particular condyle from posterior side if possible. So that is the plan, and the same thing was executed here with two posterior plates. And since there is not much, the bone anteriorly was a bit weak, I have put a plate, and through that I passed anteroposterior screws holding the condyles. And that is the post-operative picture of the same. And that's the 3D post-operative. let me just take you through, follow-up. Of course, it was grafted as well, 1 year, and that's after 2 years. The patient walks with minimal limp, of course, but pretty comfortable. You can see the range of movement. So here, the point which I want to make is, however good the fixation, here it's only the shaft which is already intact, and your coronal shear was not addressed. Once you figure out how exactly is the condyle anatomy and fracture pathology and fixation perpendicular to the fracture has given this particular outcome. And similar case, a 55-year-old. So this was operated by me in 2012-13, and that's the post-operative picture. But if you can see, the posteromedial component is ununited. So the coronal shear was not adequately addressed. The anterior posterior fixation was inadequate, and it has ended up in non-union. After 1.5 years, I have taken him again into theater and got the fixation done, and that ended up with the fracture healing. So the coronal shear fractures described mainly by Hofa in 1904, and its identification of this particular fracture is difficult, and at the same time, addressing the issue requires special skills. And the mechanism of injury is a direct anteroposterior force in a flexed and abducted knee over a lateral condyle, which gives rise to shear forces and can result in this particular fracture. So Hofa fracture is inherently unstable, and fracture configuration itself is a result of shear forces. And of course, you have got pull of gastrocnemius and popliteus, which make it further unstable. And fixation in the other plane, like you see this particular picture, obviously results in collapse over a period of time. So you need to do something more than this particular fixation to hold it. Here it is another example, a 30-year-old female, 4-week-old injury. You can see it was missed initially because anteroposterior picture looks, and the lateral also, unless you keenly see, you cannot make a fracture. So this double distal femur line, which indicates there is a Hofa component, and that's the CT scan. So all these fractures need a CT scan to diagnose, not only diagnose, but also know the configuration and pathoanatomy of the fracture, so that you can choose to fix it perpendicular to the fracture and counteract these shear forces of the coronal fracture. So here, the same patient, you can see there is a small depression of articular surface as well, and it's a comminuted fracture. So simple anteroposterior fixation in these cases might result in collapse because you have persistent shearing forces across the fracture. So the methods of fixation in this case, so 6.5 cancellous and 4 mm cancellous, multiple cancellous screws or Herbert screws. The posterior plate or a buttress plate is one which I am going to talk, and I have shown you in the first case, and small rim plates, which are also very much useful in these cases. So this is the AVO surgery reference, wherein if you can see the treatment options, the treatment of choice is given in the ORF lag screw from posterior with or without plate is the best way of fixation in these cases. and which gives a rigid fixation when compared to anteroposterior screws, something like this. So the planning is, if you put an anterior posterior screw and you have a combination, the forces are still active against, perpendicular, not the shear forces are still acting, and that can be counteracted only by putting a posterior buttress or a anti-glide kind of a plate, which gives the rigid fixation and patient can be mobilized. Here, the same patient was taken with the lateral approach, and the fracture held with an anteroposterior screws, of course, augmented with a posterior buttress plate and mobilized immediately. And that's the post-operative after an year of surgery. You can see the fracture is nicely healed and anatomy is restored. And so this posterior buttress plate, there is one article in Journal of Orthopedic Sciences, and wherein they have described the posterior buttress plate at the apex of these fractures, and it's in as an augmentation to the lateral condyle plate. So whereas it can also be used just posterior plate, augmenting the anteroposterior screws as well. So here is a patient who is around 15-year-old female patient. A bumper injury kind of patient was traveling on a two-wheeler and hit by another vehicle. You can see the anterior condyles are completely intact. Only thing is the posterior condyles are gone. Here, the patella is actually is in between the fracture fragments. So it's like a dislocated knee with a dislocated patella in an abnormal position. So if you see, the posterior condyles are also intact in this case. So intact in the sense posterior condyle relationship medial to the lateral, they are not separate. And this required, that's how intraoperatively it was looking like. So very comminuted. And the first picture shows how displaced it is. And once it is reduced and used, here I had to use a buttress plate on the lateral side and anteroposterior screws. Of course, the cartilage is like a flap, which was kept in position and then held it with these screws alone. And that's the post-operative picture. And that's almost after 6 months. And that's after 3 years. That's the post-operative picture of the same. It was, since it was an open injury to start with. This is a 3-year post-operative picture. So here is another 25-year-old male with 2 months old knee stiffness. This patient presented with knee stiffness. He had he had an injury and immobilized for a while and then mobilized, and it has landed up in stiffness. And if you analyze this particular fracture with a CT scan, there is a component of HOFA fracture and a depression of the articular surface, if you can see. And that's the depression, you can make it. And this requires this particular video, you can see the HOFA component. Same as in sagittal. Yes, that's the component. So it's already 2 months old. If you once it's exposed, you can see the depression there. The articular surface is elevated far beyond the subcondylar surface, and then held it with a small, tiny plates, 2.7 mm plate to buttress that and keep it in place. And that's a post-operative picture. So I've taken a graft from the proximal tibia and filled up the subchondral area where it was elevated from, and that's a postoperative picture after 2 years. So HOFA fracture, non-union or delayed fixations. There is one article which is actually a prolonged non-union wherein restoration of the condyle has resulted in nice fracture healing and restoration of function. This is from Chinese Journal of Traumatology. Here is another patient, similar comminuted fracture, especially posterior wall comminuted coronal shear fracture with posterior wall integrity. If it is lost, that makes it further unstable, wherein you might require something to buttress that particular fragment. Otherwise, simple anteroposterior screws may not work in these cases. So the same patient, so intraoperative pictures. So he is around 55-year-old. By that time, there is arthritis already settled in the joint, but this is the post-operative picture. The buttress that particular condyle, and that is the 3-year post-operative outcome. So coronal shear fractures. Here is another example: 30-year-old female, bicondylar HOFA. So again, so why it is missed in X-rays is your anteroposterior configuration is almost normal, except but you have double articular surface sign, which you have should be able to know so that you can diagnose these fractures. And it's a comminuted bicondylar HOFA. That's it requires multiple screws, either Hubbard screws or here I have used countersinking of screws, which are here 4 mm cancellous screws were used, and with a countersink, sink beyond the cartilage itself, and that is the post-operative picture, and that's immediate post-op, and this is 3-year post-op of the same patient. So you can see there is no double articular surface line, and the anatomy is completely maintained. We can see the anteroposterior fixation with tiny screws. I have even used Hubbard screws in this case. So how about association with distal femur fractures? So it is almost seen in around 38%. Here is a study which is published in Journal of JBJS, wherein it is almost associated in around 38 to 40% of comminuted distal femur fractures. So coronal component should not be neglected in any of the comminuted distal femur fracture, which has to be addressed. So this is an example of a similar patient who is around 20-year-old, multiple trauma patient, open injury. And here, so you can see the trochlea is a separate piece, and there is a coronal component which has to be addressed intraoperatively. The strategy is how to get a anteroposterior fixation and mediolateral fixation, followed by something to fix, since it's a comminuted distal femur, either a plate on the lateral buttress plate, or bicondylar plating also is advocated in these cases. Here the anteroposterior fixation followed by lateral plating was planned, and same is executed. So that's the fixation plan, and that's how condyle restoration, anatomy of the condyle was restored with small tiny screws after anteroposterior fixation, and then for the metaphyseal or a metadiaphyseal combination, biological plating was done with a bridge plating was done with a list plate. So that's the post-operative picture. You can see anteroposterior long 6.5 cancellous screws, and then tiny screws. followed by this is after 1 year of post-operative picture. You can see the function. The take home is coronal shear fractures are quite unstable, especially when you have comminution on the posterior cortex, and prolonged non-union results in deformity, needs open reduction and articular reconstruction, and whenever it is needed, filling up with a graft, and posterior buttress plate improves the stability. So sometimes small tiny plates are very much useful when you have a rim kind of a fracture associated with these fractures. Thank you.
Thank you. Thank you, Dr. Srinivas. Excellent cases, very, very difficult cases. Even though I don't do trauma nowadays, but whenever I was doing trauma, these are the, HOFA fracture was the most difficult fracture to treat and fix it. That was the, my, difficulty. Just before I hand over to the moderators, can I ask you, there was a Lerner classification for,
Yes, sir.
HOFA fracture. Is it not, followed nowadays, type 1, type 2, type 3?
Exactly, sir. That slide somehow it got missed. So little classification is routinely used classification wherein you have type 1, type 2, type 3. In type 1, the fracture is relatively anterior to the lateral collateral ligament, and type 2 is posterior, whereas type 3 is oblique configuration. But either way, you need to know after you got a CT scan, which is more commonly used nowadays. So you should be knowing the fracture configuration and should be able to address it either. Please, sir.
The fixation, depends on what is the type of fracture. How to put that buttress plate, that is the crux. And after putting whatever Howard screw or or countersicking the screw, you need to put that buttress plate. That is the crux of the problem, to the failure of the fracture. And whenever it becomes little older, part of the fracture fragment gets absorbed and reduction becomes difficult.
Completely agree, sir.
That is the problem. We'll go ahead with the discussion from the moderators, and before we close, I'll just present one case of neglected HOFA fracture which I have managed before we close. So now I hand over to the moderators, Dr. Ankit and Dr. SELVARAJ, and of course we have Dr. ASHISH PHADNIS is here. He is an excellent trauma surgeon also. So we can have questions from them.
Sir, great talk, amazing, and I must congratulate you on the amazing talk and amazing series of cases that you have presented. Sir, I think we'll start with the very beginning. There are a few queries, or rather a few things that I feel that need to be discussed for the general orthopedic surgeon who needs to know a few things regarding HOFA's fracture. So, regarding the approaches that you normally use for a isolated HOFAs or bicondylar HOFAs, would that include extended swashbuckler sort of an approach, or would you also err upon doing approaches like the posterolateral and posteromedial, which have been described for isolated HOFA fractures? Is this something that you have used in your experience?
Yeah. So when it is comminuted, I often choose to use fast buckler's approach, but more often I prefer mediolateral approach. So wherein, especially when you are putting when it is associated with shaft fracture or distal femur comminuted kind of situation. So I take a lateral approach and medial separate incision. So, but when you have an extensive comminution, it's a good idea to use fast buckler's approach in this case.
Okay, sir. Dr. Silva, Dr. Karthik, is that what your experience is with these fractures as well? Or do you also use those posterior sort of approaches for isolated HOFAs of a single condyle? You're not audible. Sir, you're not audible.
You have to unmute yourself.
First of all, I have to thank Dr. Mohanty and the team, Deepak, for having me in this session. It's wonderful. In fact, I've been following this controversies, talks, and they've been quite useful, I should really say. And it has been practice changing as well. So, coming to this talk in particular, Dr. Srinivas has made us feel like these are very easy fractures to fix. He has shown such complicated fractures, and the post-op X-rays and outcome, the clinical outcome looks so amazing. So it just shows your skill and expertise, sir. It's wonderful. Now, regarding your query about the approach, normally I make the point to the plate whenever there is a fear of this shearing off. But most of the time, we end up sort of opening either medial or lateral and then fixing it with anteroposterior screws if it is not comminuted. In fact, I had this question of, how low do you have to go with the plate, and what sort of plate you use normally? Dr. Monty, yourself, Dr. KASHA.
Shall I answer?
Yes, please go ahead.
Yeah. So the thing is, whenever you have comminuted fracture, in these cases, the most important thing is we need to plan your anterior posterior screws and your mediolateral plate if you are using a lateral buttress plate or a list plate. So your anterior posterior screws should be, near to the subchondral if it is possible when you want to bring it down a bit. So I preferably use a plate by Smith & Nephew in these cases where you got good space to use mediolateral screws anteriorly. So and you got a good space given in the plate construct to accommodate these screws.
What is that?
Smith & Nephew plate.
No, Smith & Nephew, you mean the distal femur plate, or is
distal femur plate? Yeah. So when it is associated with distal femur fracture, so you need to plan your anteroposterior screws relatively near to the subchondral, and then use a distal femur plate, wherein you can put mediolateral compression screws also, for which you got a provision in the plate itself. So, but I have shown you a case where I have used a different kind of a plate also.
So regarding the plates that you use in the either posterior to buttress or the anterior plate, you use a lot of 1/3 tubular plates.
Yes.
Actually, that is something that I wanted to impress upon, especially the first case where you had put in 2 plates which were right posterolateral, but in a failure case, in my experience or something that I normally do, I use possibly a humerus LCP 4.5 narrow sort of a plate because I want a more sturdy fixation. What is your take on that, sir?
Completely agree with you. It is not sturdy fixation, but the thing is, if you see the anatomy, if you want to put a plate on posterior surface or posterolaterally or posteromedially, these sturdy plates doesn't sit there, and they won't give the buttress effect also. And whereas 1/3 tubular plate, it gets contoured nicely, and you can put 2 screws into the condyle also whenever you have type 3 kind of a fracture configuration. Or even the case which I have shown is type 1. Even in that case, you can nicely buttress it from posteromedial and posterolateral.
And what is your mobilization protocol, say, for the first case that you presented? Would you go ahead and do a range of motion or a CPM maybe when the suture removal is done, or would you wait even further?
No, immediate. I allow them to move their knee immediately the first post-op day itself. For the reason that it has got a good rigid fixation. Once you fix it, you have got an anteroposterior screws, and you have got a posterior fixation which is quite stable. And almost all these cases were mobilized from day 1. And if you allow it to, if you delay it, probably it might land up in stiffness.
So these fractures actually displace quite late. Until about 4 or 5 weeks, the X-ray looks all right. Then 6th week, you get an X-ray, the condyle has gone back again up. So there is
Yeah, I
there is
agree with you. I agree with you. They are the late phase. If when you see, there will
Yeah.
be, you see some parts is observed, and there is the reduction looks little disturbed, and then you are little puzzled what to do.
There is a tendency to actually immobilize the patient for some time in these. That is the reason, because of late displacement. So you feel that if you put a plate posteriorly, that will be avoided, isn't it, sir? Srinivas, sir?
Exactly. That's
Oh.
exactly.
Especially in the comminuted cases, sir. And
Yes.
regarding the handling of the gastrocnemius, so do you, for putting a 1/3 tubular plate, do you really need to take off the entire gastrocnemius from one of the condyles, or is it partly that you remove it? And what do you do with when you've removed it? Do you like put it back
Actually,
somewhere? Like really,
yeah.
you feel that it'll just as you move along with the wound healing, that will really consolidate and get back attached to the periosteum of the distal femur.
You.
That was my question. I'll add to that question. So, what are the precautions you should take? Because it's a little unfamiliar territory for a lot of general orthopedicians to go. Where we are worried about neurovascular structures and all that. So, please tell us your tips and tricks for that.
Yeah, excellent question actually. So for that reason, I take medial and lateral separate incision so that they are a bit, posteriorly oriented for this particular reason. And like if you can observe yourself, whenever you are putting a distal femur locking plate, you can actually go up to the posterior surface of the condyle. So when you dissect it, and you are not even going to the gastrocnemius. So it's a bit medially, the gastrocnemius gets inserted a bit medially, and you are on the posterolateral surface, not necessarily posterior also, but even you can put a posteriorly also without reaching your gastrocnemius. So is true with the medial side, and it is risky only if you are going beyond your gastrocnemius. When you are trying to stay lateral to it and trying to put this plate on posterolateral or posterolateral border.
Okay. Right, sir. Again, I think one of the cases that you showed, you got a post-op CT scan. Is it a routine in your practice to get a post-op CT scan for these patients as well?
No, it's not routine. Only for that particular case I had to do. But since it was very complex and I wanted to know the screw territory and whether I am perpendicular to the, fracture fragments, and only in that particular case, otherwise no post-operative CT unless it is some acetabular fracture fixation.
And in a few of your cases, you did show that you've used mostly 3.5 screws as a part of the 1/3 tubular plates, and
Yes.
you use the 6.5. So in my personal opinion, I feel that if the fragment is large enough, I prefer to use screws that are 6.5 or 7 mm. Is that what you normally aim for, or do you feel that 3.5 are good enough for large fragments as well, given the amount of shear forces that are there on the posterior condylar fragments?
I completely agree with you. Whenever it is possible, when it is a big chunk, it's better to use a 6.5 mm screw. You can, with a single screw itself, you get a good stability. So, when it is comminuted and something like, with small fragments where you have got tiny subchondral bone attached to it, in such a situation, Herbert screw. Or when I am planning a distal femur plate along with it, then for 4 mm or 3.5 screws.
Sir, one other thing is, as I told, we see some late displacement. Say everything looks good at 4 weeks. At 6 weeks, you find there is a little bit of a displacement. Now, up to what level can you accept it, and when will you again go on intervene? Mohanty sir can answer, and Srinivas, obviously, in your cases, it doesn't happen at all. But this is something which people
completely agree. See, I won't just operate if it is around 3 to 4 mm, collapse or displacement. If it is beyond that and causing a varus, yes, you need to go and do something.
The lateral hoof also sometimes displays and patients go in bit of
Correct.
a
Even if it is causing a deformity, it is not only it not only causes deformity, but also it gives rise to instability of the knee.
instability, restricts
Because of
flexion.
it. Yeah. But I haven't done any revision for 4-5 mm of collapse. It's wherever there is a implant failure and big displacement, something like that. Yes. Sir, Mohanty sir, you can answer this.
Can I?
When to actually, Ashish, yeah.
No, I wanted to ask another question. You can ask. Mohanty sir can come in here.
Yeah.
So what I wanted to ask first is another question is these fractures are a part of a polytrauma, or you're generally doing them in a supine position with 2 incisions. Do you have any tips to sort of judge the reduction and the position of the clamps, or any other aids you use like shank spins and all to get a proper reduction, and how easy it is to assess the reduction with direct visualization?
Yeah. So I think direct visualization is better way of actually assessing the reduction. But we are used to AP and lateral views. AP is you cannot make a big difference in AP, but in a lateral view you can make it if it is a bit 1 or 2 mm collapsed. Also you can actually see the subchondral line. But what I prefer is clinical. So you have exposed the condyle, and then it is easy for you to check your reduction under vision.
Do you have to get the leg in extremes of flexion or extension to
actually these fractures, they get reduced in extension, but you don't get much space in extension. So you have to keep the limb in 20 to 30 degrees of flexion, where you can it's better way of working.
Okay.
Yeah.
Do you always use a bolster for that handy?
Yes.
Use
so
sheets, because sheets tend to really compress down, and intraoperatively sometimes there is difficulty, especially. So what is your personal preference? Do you make a bolster out of a pillow that is draped, or do you use gowns sheets to facilitate the reduction, especially with isolated HOFA fractures?
Right. I have a triangular pillow or triangular bolster kind of thing, which is unequal, which supports the shaft of the femur, and you get around 2 pillows I have, where you get around 30 degrees of flexion, and another one you get almost around 90 degrees of flexion.
Okay. So you use both of them depending on the kind
the
of
need. Yeah, correct.
Okay, that's a great technique, sir. And another thing that you really impress upon is how to decide between a screw and a plate. So is it just the combination that is there that will incline you more towards plating, or is it also something to do with the fragment size, where you feel that a larger fragment would need a plate rather than just a screw, which is even if it is a 6.5, you feel that no, this is a big enough fragment, I would need a plate for this as well.
So my answer for this is it's from the best way is to have both anteroposterior screws and posterior plate, even for a big chunk where you have the full condyle also. But whenever there is a posterior comminution, cortical comminution, so it is mandatory to put a plate. Plate is a must. Whereas it's optional in case of a big condyle fragment, where you can put 2 nice 6.5 mm screws. The issue is in extension, nothing happens. When you are flexing it, you have the shear forces still on, and your fixation is in another plane, the anteroposterior. So for that reason, always, two implants. One is posterior and the other one is anteroposterior screw. But when it is posterior comminution is there, it's a must that you have to put a posterior plate. That's my current way of dealing with these fractures.
Definitely, sir. Dr. Ashish, Dr. Karthik, do you follow a similar protocol for your OFA fractures?
Fortunately, I don't see so many comminuted fractures as much as Dr. Srinivas is seeing. But yes, I mean, if there is a slightest of the doubt, it is just an extension of the incision, and then I would have a low threshold to buttress it if I feel that there is a lot of comminution and instability.
And what is your plate choice if at all you have to buttress? Would you still use a 1/3 tubular or a recon or a narrow DCP or something like that?
So honestly speaking, I've not used a DCP for a simple reason that I find it quite bulky. As Dr. Srinivas, it is very easy to contour a 1/3 tubular because I would want it just as an anti-glide effect. So my primary fixation, I'm relying on the screws. Basically, most of the time it is either now here Srinivas has mentioned about 6.5 mm screws, but I've ended up using a lot of 4 mm long screws in the AO 4.0 cannulated canceller screws, because they can be a little bit less bulky and it can be countersunk, and we get good lengths in them as opposed to Herbert screw. I think we get only up to 30 mm in length. So even if you choose to use a thicker Herbert screw, you wouldn't get them.
Right.
So thinner plate, and we never use a rim plate, but that is a good idea that what in one of the cases Dr. Srinivas showed.
Right. Sir, in the second case, if I can really bring you back to the cases that you showed, you had a case which had a failure, I believe, which had a combination, and you said that there is a shear fracture but I could also find there was a sort of a medial combination or a medial gap in the metaphyseal reduction. I felt that was the reason why that fracture particularly failed. If you could go back to the slides and if you could really show it to us if it is possible.
Just a second, I'll let me share. Second case is, so do you want to say this case? Your voice is not audible.
Dr. Ankit, you're muted.
Yeah. I think so. In the case where the plate you said had failed, and you probably thought that it was due to
oh, the first one. That's the first case, right?
No.
This one, right?
Next one. No, not this. No, not this one. Not this one.
See, this is where it has landed up in non-union because my fixation doesn't have an anteroposterior. So although I have got mediolateral fixation onto the medial condyle.
Okay.
So if you can see these towards my left, so you have got fixation going up to the medial condyle, but it is not perpendicular to the fracture.
So
and that has.
Okay. So in this particular case, had you used a medial plate other than I understand that you're saying that you did not fix the coronal fracture. I agree with that.
Correct.
But in this particular case, had you used the medial plate, do you think that the failure could have been avoided?
Maybe yes. And I would put it this way: if it is posteromedial plate, it is much more better actually.
So I think we're slightly off topic when we are talking of a distal femur fracture rather than talking of a coronal plane fracture. But Dr. Ashish, what do you feel about these sorts of fracture which have a significant medial combination? Do you feel that a longer plate or an addition of a medial plate would have actually prevented failure in this case?
So this day and age now, with the knowledge that we have on distal femur non-unions, so this will go for a supplemental fixation or maybe a strut fibula or maybe a kickstand screw on the medial side. But looking at the amount of combination, a medial plate with a separate incision would be in this day and age. In the last few years, we have been starting to do that.
On day one, I believe so.
Yes, the primary fixation.
Okay.
So I agree with you.
How many years back is this done?
This is This is from 2014 or something.
Yeah, so I think our knowledge in the last few years has been really, we have been hammered of dual plate, dual implants,
Dual
and
plate, yeah.
the middle spread. So nowadays, no one would do that, but this probably was the standard of care in 2012, 2014 era, isn't it?
Right.
And for a middle plate, would you use a separate incision on the medial side, or some people try to, really lift it off and put an anteromedial sort of a plate at times?
Srinivas?
Oh, yeah. So if it is primary situation, if I get the same case today, so I would do lateral fixation will be same, but medially, I would definitely put a medial plate, either posteromedial or medial. I would prefer to put posteromedial plate. So
With a
small
separate-
1/3 tubular kind of thing.
So two separate incisions, right?
Two separate incisions, yes.
Yeah. So that's what he was asking, Dr. Ankit was asking. So yeah, I would agree with that two separate incision. My thought process was that, by two separate incisions will give me a better surface to plate on. I would not compromise on the surface of my plate, and I would get the plate absolutely where I wanted. But if it's a single incision, I might be restricted by the soft tissues to put it on the best possible position. I don't know if that's your experience, or Dr. Karthik can also enlighten.
Can I ask one question?
Yes, sir.
In one of the cases, you showed there is a small cartilage fragment which you are fixed.
Yes.
Actually, does it stay, or it just gets absorbed? This cartilage fragments. I would have taken it out and thrown it. But
Yes.
does it help? Means just we are discussing everything in bit detail. So
Right. Agree, sir. So if it is just a cartilage flap without much subchondral bone, yes, it's better to throw it away, and end of the day it acts like a loose body inside. So, but when it has some kind of a subchondral bone, which is the scenario. Most of the times you have some subchondral bone. And for these cases, for that reason, when you are lifting in a depressed situation, you have to lift it far away from the cartilage. So almost retain around more than 5 mm of subchondral bone should be at least intact. Otherwise, as you said, it gets absorbed later. Yeah.
So should I share my case?
Yes, please,
Please,
sir.
sir.
I'll just share the screen. So this is a case of neglected HOFA fracture. So here is a 56-year-old male, diabetic, who had a fall in June 2011 and sustained a lateral HOFA fracture of the left knee. And one surgeon did open reduction internal fixation with 2 screws. And subsequently, after 4 years, that is in 2015, he removed those screws. And when he presented to me in 2015, there was a complaint of pain and a sense of giving way. Those are the X-rays, and this is the patient. So on examination, there was a genu valgum of about 30 degrees, hyperextension about 20 degrees. There was a good healed scar on the lateral aspect of the lower third of the thigh. As you can see, this is a scar, and tenderness was present. And there was lateral instability. So it was a correctable deformity. It is almost going maybe little valgus or correctable deformity. There was full range of movement. There was no neurovascular deficit. This is how he was walking, with a valgoid gait, if you see it from the front or from back, and with a hyperextended gait like that. Valgoid and hyperextended back. So these were the X-rays when he presented to me. So after screws has been removed. And next I did a CT scan. So these are the CT scan, little close-up view shows there's a non-union of the HOFA fracture there. And these are the screw, sites where the screw was there earlier. And this is a little 3D reconstruction of that fracture. So what will you do, Dr. Srinivas?
Pretty challenging case, sir. And again, most important thing is if it goes into non-union, usually it causes instability and deformity. So now you have instability and deformity both.
Yeah.
And
It's a 4-year-old non-union. Yeah.
4-year-old. Yeah.
Yeah.
So, but it is better to reconstruct this particular non-union, sir. I would prefer fixation of this, and obviously I'll counsel them for future totally replacement, but I will restore this particular non-union.
What is your approach and how will you proceed?
So this is a lateral approach, sir. A regular lateral approach, and so cleaning up the fracture site, and then keep the limb in bit flexion so that you can reach the posterior side, and then I'll try to put a posterior buttress plate. I would grab this particular thing. I'm okay even if the condyle anteroposterior length comes down a bit, and you see a gap in the cartilage. Also it is okay, and the thing is to address this instability is the main issue.
And I will put graft between at the fracture site in order to because anatomically it cannot be reduced. The fracture fragments is observed and all, so reduction will be difficult. So you need to put some kind of graft and then pass Hubbard screws.
Yes, anteroposterior screws, and then plate on the posterior surface.
That buttress plate, what you have shown. Okay. And Ankit,
but it is difficult task, right?
I know. I know. But since it is a full range of movement, tissues are all supple, so probably may not be that difficult to do that.
Yeah.
Ankit, also you will do the same thing?
Similar plan, but what is the age of the patient, sir?
56.
Of course, sir. It has to be osteosynthesis, no doubt. And yes, has to be plated posteriorly. Again, my preference slightly is a recon sort of a plate for this, because I want more sturdier fixation. Although other tubulars, I don't really, unfortunately, don't have much experience. But based on what I've learned today, maybe I'll use more of them because they're easier to contour and easier to place. And bone grafting, of course, has to be done with clearing of the fracture site.
And same lateral approach.
Lateral has to be lateral approach with a bolster to keep the knee flexed, allowing gastrocnemius to relax, and getting behind the condyle would be easier with that.
Okay. Dr. Selvaraj?
Sir, what is his disability?
Disability is, pain and sense of giving way. Because knee is unstable now, and is getting pain. It's walking, but with, tolerable pain and sense of giving way.
Okay, sir. I think we all agree that it needs to be fixed.
Yeah.
But let me ask you a question. If this patient was 65,
you
are planning TKR with the non-union of the FOFA.
Yeah.
So please tell us what are the tips and tricks?
you said said boomerang.
I would left boomerang. Not even 65, 75.
The idea is to learn from you then.
No. What I'm asking, even 65, you will fix it. Is the consensus to fix it also?
Yes. Because the arthroplasty for this would sir, I think you can guide us better, but I think arthroplasty.
I agree with it, sir. Even 65, I would like to go for osteosynthesis initially and reserve replacement for a later date, because it is quite difficult to do arthroplasty in this case.
And no, we can.
The constraint for this is too high, and the level of probably a distal femur replacement would be something that would really be required, and that is not expected to run for more than maybe 5 years or 10 years.
Okay. No, we can fix it and do the replacement at the same time in this patient. If we have to do a TKR, we can actually fix it with screws and do the TKR at the same time. It's possible. I've done a similar case.
Okay.
So that's why that's what I was expecting from Dr. Mohanty. I think
What was the age of the patient which you did?
that was, I think, 67 or something. He had a very
Okay.
small BOFA. It was not
Okay.
big. It was non-union BOFA and arthritic knee. So
Okay.
we actually put a couple of screws and then proceeded and then did the TKR as well.
Okay. Ashish, you also agree to fixation?
No, I would agree with the fixation because I probably would find that to be a easier option in my hands rather than a replacement. Maybe get some bone stock and then replace it at a later date.
Sir, please
Okay.
correct me if I'm wrong. This is a large condylar fragment with possibly the LCL being attached to this fragment itself. So if we
Yeah.
don't do an arthroplasty with fixation of this condyle also,
Yeah.
what is the level of constraint that you would aim for? Would it be a CCK sort of a knee or a PS would be
I
again?
think I'll keep a CCK, I mean, a constant condylar strain standby and see on the table how things go. That is what actually it is. So, the confusion was to fix it or replace it. So, I kept both the options ready, but I went by a antra-midline approach because I am more conversant with doing a knee replacement rather than fixing it, which has failed earlier by one surgeon, with 2 screws he has failed, and now this is the second surgery, maybe third surgery, because he took out the screws also. So this is how, after opening the joint, this is how the joint looked like. See, I'll just take the patchy cartilage loss, and this part of the femur was impinging against the tibia there, and there's a deep groove on the articular surface of the tibia. Still, you would like to fix or replace it?
Shows the fractured piece. Where is that piece?
That piece is proximally displaced, is not visible here. I'll show you in the subsequent slides.
So now the tibia is also involved.
Yeah.
Yeah, so fixing it is not going to solve that problem.
But the
Here, the defect looks a little bit manageable. I mean, if you have a stem and augments, it looks that this defect can be manageable.
Sir, correct me if I am wrong. So your defect looks more on the intercondylar area rather than
it is an anterior aspect of the tibia. It's anterior aspect of anterolateral, where it was impinging against this part was impinging against this, and there's a deep groove there. Sir,
again, the patient primarily came with instability. I think that is what the initial picture was.
Yeah.
So, pain
and tenderness was there, pain was there,
okay.
And he wanted something should be done.
So then obviously it has to be arthroplasty based on the introp findings, no doubt.
Yeah, that is how I decided to do a TKR on the table itself.
Of course.
And now I'll show how I went ahead with doing a total knee replacement. Now, dislocation was difficult. I tried to dislocate it. It was difficult because that fragment which is, there behind, it was impinging upon and it was not allowing the tibia to come forward. So what I did, I took the proximal tibial cut and distal femoral cut, got some space, and then I tried to mobilize this fragment. This fragment is displaced quite, proximally, and to mobilize that fragment, I use this AO, toothpicks, which are there in the AO set, but these are the locally manufactured toothpicks, which are available in Princess Street in Mumbai. This cost 13 rupees. You will be surprised. Only 13 rupees. So I had a couple of them just to mobilize this fragment. So next I brought the fragment into a reasonably good position here and then fixed it 2 K wires from lateral to medial like that, 2 K wires. Next, I used, this epicondyle was there here. So I used the interepicondylar axis. It was difficult to, decide about femoral component rotation. So I used a parallel to tibial cut technique by Dr. Ranawat. And after taking the tibial cut, actually this groove was much smaller. And though there is defect is present, there is a small groove. So parallel to tibial cut technique in order to decide about femoral component rotation. Then this is after taking all the, epi cuts and chamfer cuts. And this is the fragment. There is a little bit of space out there. So I used a Herbert screws from anterior to posterior and then took out these KURs in order to fix that fragment. Finally, this is after fixing the Herbert screws, how does it look like? And next, because this condyle was deficient and here there is deficient, so I had to use screws and cement augment. So 2 screws here, 1 screw here, to use cement and screw augment, build up. So distal femoral and proximal tibia screw and cement built up. And that is the post-operative X-ray. Ideally, I would have put a stem extender on the femoral side because that fragment is itself is such a graft. But unfortunately, that day, the stem extender was not available. Actually, I was doing this case at Bhubaneswar. It was not in Mumbai. So I couldn't, the company people didn't have a stem extender ready on the table. So that is 6 weeks X-ray actually. And that was a 6 weeks function of this patient. Reasonably good movements and walking. And this is 6 years follow-up of this patient in 2021. And this fragment looks probably it is united and he's painless and he has got a full range of movement, full extension. So I tried to find out whether a TKR has been done in a old HOFA fracture primarily. And I could find only one case report which is described in South American literature where they have done a total knee arthroplasty in a patient with HOFA fracture pseudoarthrosis. But they have not mentioned about the follow-up of this patient, that how much follow-up. So that's it. Thank you for a patient hearing. Any comments or anything?
Nice case, sir. Right decision intraoperatively.
Yeah.
So might be I don't know. Would you have still done a fixation by looking at?
So
Here, mortars
probably having seen the joint, yes, no to osteosynthesis. But if it were to be a lateral approach, probably I wouldn't have seen the lateral condyle.
Yeah. And tibial condyle also, I don't know how far you could have seen. Correct. So you might have done a 2-stage surgery. Maybe first stage you fix it and whatever position, and later on. Yeah. So we are almost ran out of time. Any other questions or?
I think it's wonderful, but I mean, for people, I mean, who are of, I mean, I had said osteosynthesis, but retrospectively, then in my armamentarium, we should make the provision for a knee replacement, and that too an exhaustive one with stem augments and everything.
Yeah.
That probably would not have crossed my mind to keep it on the table. So the removing that big chunk could have been like something like removing a very big piece of osteophyte. That is what is causing the tenting of the ligaments and everything.
Yeah.
So you got a cartilage. It is not difficult to extract it because you have got a space beyond that, right, sir? Hopefully.
Yeah.
After taking a cut, of course.
Yeah. After taking the cut, so that gives you some space in order to remove that. Otherwise, it was difficult to take it out.
And one more thing which was interesting was that we initially thought that the big piece of OFA is probably having the attachment of the LCL. But did it look like, or was it because you have fixed it? That's why the stability is now restored.
No, because I had fixed it, then the stability was restored. That was the thing.
Right. So it was
the patella as well for this case. I
always resurface the patella
because what was the implant, if I may ask?
J&J PFC fixed bearing, PFC PS posterior cruciate.
You had a TC3 as a backup. I'm just asking, sir.
Sorry.
You had a TC3 as backup for this.
It was not available for that case.
And would you have preferred using it?
I would have preferred to use a stem extender at least on the femoral side.
Okay, sir.
And J&J system allows that. Only on the femoral side you can just put a stem extender.
Great.
So thank you very much. And I think we'll have to wind up. We are overshot the time by 10 minutes. And I'm really amazed to see so many complex cases from Dr. SRINIVAS. I never believed that there will be so many HOFA fractures. We'll be having one surgeon having so many HOFA fractures with him. And along with, it is not simple also. It are all complex cases with combination, with associated with supracondylar fracture. And really, I'm grateful to you for sharing your experience with the HOFA fracture, which is such a difficult topic. Thanks a lot, Dr. SRINIVAS and Dr. Ankit. Thank you very much. You are really prepared for the discussion part, which was helpful, and we discussed all the nitty-gritties, minute things in each case, and that was helpful for all of us. And even Dr. Selvaraj, thank you very much for joining today. And we also got so many, important finer points from you. And moreover, at last, Dr. ASHISH also, our own ASHISH, he also discussed so many things. Thank you very much for joining today. And again, after 2 weeks, we will be doing another episode of this controversy consensus on a different aspect. I now hand over to ASHISH to wind up the, webinar.
Thank you so much for the opportunity, sir.
Thank you. Thank you.
Sure.
Thank you very much, everyone, and especially to my dear friend SRINIVAS KASHA for taking us through what is the recommendation and what are his recommendations and tips and tricks for fixing these challenging fractures. No doubt, these fractures do come to us often, not very often as much as the rest of the fractures, but then one should know what are the options for us to execute when we are sort of dealing with these situations. I would also like to thank Dr. KARTHIK SELVARAJ and Dr. ANKIT KHURANA for being with us and for moderating the session. Thank you very much. You made it very interesting, and we hope to see you and all of our viewers to see you in our couple of weeks' time with a new session of controversies and consensus in orthopedics. Last but not the least, I would like to thank Dr. Neeraj Bijlani, Dr. Ashok Shyam from OrthoTV, and Poonam from OrthoTV for supporting us in this endeavor and being with us. So bye for now from my side and Dr. DEEPAK GAUTAM. We would like to thank you very much for joining us. Thank you very much, sir.
Good night. Good night.
Good night.
Poonam, you can stop,
You can stop the recording.
Stop the live streaming also. You are there?
Poonam?
Yeah.
No, she's not there. She's not.
Okay.
It is still recording.
You can close now then.
Okay, I'll call you, sir.
Yeah. Thanks.
Okay.